Kia ora, Tim. Welcome to your interview. And I often like to start these conversations by thinking about where your inspiration to become a clinician might have come from. I understand you've always had bilateral sensory neural hearing loss, which has significantly worsened over recent years, I understand. And do you think this might play a part in your career choice? Do you think it might have shaped how you practice as a doctor as well?
So I was sort of diagnosed with bilateral sensory neural hearing loss. So I guess at that point, moderate severity. I was about 5 or 6. And it was by my local GP, Dr. Hall, working on the Lancashire coast in the, must have been the late 60s, early 70s then. And he did an ear, nose and throat attachment at the local hospital. So he looked after me. He did make a recommendation I ought to wear some hearing aids, which I did for a short time at primary school. Hated wearing them because they are stigmatizing. I'll come back to that in a minute. And only got hearing aids back in my last year of medical school and worn them ever since then. And Dr. Hall was always a supporter of me. When he heard I was wanting to go to medical school, he remember him coming round to my house with a cassette tape, which is in the box somewhere, of heart sounds, and said you might find those helpful, particularly with your hearing loss. So I suppose that perhaps just touches on perhaps how doctors have seen hearing loss, particularly when I was at medical school in the 1980s. I do think it was seen primarily as a technical matter that could be fixed either by sitting near the front of a lecture theatre or by getting an amplified stethoscope. I don't remember anybody ever discussing with me the challenges that would be faced in a surgical or anaesthetic attachment and mask wearing, and the effect that would have on your ability to hear. Because I think I just emphasised that hearing loss is a stigmatising condition. It gets less stigmatising as you get older, I think. And I'm a great fan of Irving Goffman's work on stigma.
Hmm.
Sociologist Irving Goffman, and he says that people with stigma always have to want to pass as normal or try and pass as normal because you are in an ableist world and you can't keep asking people to repeat themselves indefinitely. So you have to pass as normal. And so the way I've done that, because my hearing has got worse, but it's always been moderate loss, is I've never been able to hear everything anyone ever says to me. Sometimes a lot, sometimes nothing, but somewhere in between. I have to say, I think medical choice in terms of a career was driven positively by other factors. It wasn't driven by my hearing loss. I think it was driven by great exposure to both general practice in Edinburgh from John Howie and his work on diagnosis was a great read in the sort of mid-late 80s. And also, I have to say, the psychiatry teaching from Professor Robert Kendall were fantastic as well. So those have been my two early passions, and I think they were driven by positive medical school experience. And also, I think experience bearing in mind hidden curriculum around being treated humanely and respectfully and listened to and your opinion valued on attachments such as general practice and psychiatry. So you asked, so that's the answer to career choice. Okay. Do you
Yeah.
want me to say anything about how it might work, how it might have affected me working as a doctor?
Yeah, I think you've indirectly already started to answer that question.
Yeah. Yeah. Okay. So I think that goes back to my comments about what are the skills you have. So I
Yeah.
think you can see any disability as a deficit, but I think it's important to see disability as a strength as well, because the people who are disabled, if they succeed, then they will have developed strategies to succeed.
Yeah.
So strategies to succeed in my case are really around, I think, active listening through basically using reading the room and lip reading. And so in the consultation, thinking about it as in the consultation, I guess in the consultation, it's really been sensitive to patients' nonverbal cues, reading where they're at, making sure I lip read, obviously being open to people about being deaf. I still do wonder how many by the way comments have got missed if they were not said in with my visual field, because I probably wouldn't have heard it, but I can't do anything about that. But I think being a doctor is more than just individual one-to-one consultations. It is about working in teams, particularly as I've worked through the university. It's around chairing meetings, leadership work. And I do believe that finally tuning skills around lip reading and particularly reading the room have made me a good chair. I have had feedback for that, but I do believe it actually helps how you work with people, because I think you're much more switched on in terms of reading what's happening in a meeting, perhaps sensing people might not perhaps agree with something, proactively dealing with that, asking those questions. So I think there are strengths that I've developed through having the deficit.
And you mentioned a little bit about the values that you hold with respect to general practice already, but can we go next to your perspective on generalism and what that means in clinical practice? And I'm particularly interested in your thoughts on whether generalism adds more value in the rural health setting, compared to more
Sure.
urban contexts, perhaps.
Sure. So just thinking about generalism then, I guess generalism has a number of dimensions. I think first dimension is generalism is about breadth and specialism is about depth, in terms of actual content or clinical content or area. But I do believe journalism is also about developing long-term relationships with people over time. And I think specialism, and I have to be careful here because there are specialists who will develop important long-term relations with their patients over time. I'm thinking of psychiatrists, I'm thinking of people who do chronic medical condition management. But I think in general, specialism is more around single disease-based episodic care. And I also want to bring in something from Aotearoa here as well into generalism because I work in New Zealand, which is a bicultural country. So there is a Maori whakataukī or proverb, which is he tangata, he tangata, he tangata, which is it is the people, it is the people, it is the people. So that to me, in the context of generalism, is really emphasizing that generalism should prioritize human connection, community, and relationships. Okay.
Mm-hmm.
So that's generalism that's what I think generalism is. I mean, there are other things you can add to that, managing complexity, managing differentiated disease. But I think those, I think, are the core things, really. It is about developing relationships with people.
Yeah.
People
Mm-hmm.
have diseases. It's not about disease, it's about people who have diseases. So you asked me about it being perhaps more value in rural areas. I think that's an interesting question. I think it's certainly true that I've emphasized that journalism is about human connection, community, and relationships. And, if you work as a rural practitioner, I work personally as a rural practitioner in the UK. I worked up in the Pennines for a number of years, and I also worked in the Fens of East Anglia. And I guess reflecting on that, and also from talking to my colleagues in New Zealand, because I do a lot of work with rural generalists, rural medical generalists, and also rural GPs in terms of research, is the emphasis around looking after a defined population of people over time, living in the community, perhaps being in the goldfish bowl, developing the strengths of being with people from cradle to grave, the satisfaction of caring for people over time. And also, I think, as well, obviously developing strategies to manage your own need at times to not to be quite so immersed in that community as well, but there are ways you do that in a positive way. So I think that's rural, and I've been reflecting about other practice as well because I don't think urban is homogenous.
No.
I mean, I've worked as an urban GP, and I've worked in suburbia. I've worked in areas of high deprivation. I've worked in areas of very high deprivation, and I think honestly, I do think it applies in other settings. And I think particularly in urban contexts such as urban deprived practice, where often you are the person that they met for the first time, who's prepared to treat them as a person who wants to listen to their story, and they're just a number in the benefits office or other issues going on. And I think that's really quite important as well. So I think my reflection is journalism is really important when you're dealing with patient groups who really, I think, need your practice team to provide them with personal, continuing primary care.
Yeah, that makes a lot of sense. And I suppose bringing the geography into it, how has your life been shaped by, your own geographical variation? And did you spend your childhood in England, in Northern England, as you were saying?
Yes, I suppose I had a pretty boring sort of, low middle class existence growing up on the Lancashire coast, being a bright grammar school boy, and going to Oxford University in 1982, which was the entry into a different world,
Mm-hmm.
and then finishing my medical degree at Edinburgh in 1989. So yeah, so I mean, I certainly didn't have a particularly ambitious geographical life as a student. It's interesting how I came to work in New Zealand, really. At one level, it was actually serendipity,
Mm-hmm.
because what the actual reason for moving was being approached out the blue back in 2013. In fact, at that time, I'd only recently moved to a job at the University of Birmingham. to apply for the Breaking Professorship, the Elaine Gurr Professorship of General Practice in the medical school at the University of Otago. And I think at that point, it really ticked a number of boxes in terms of my kids, who must have been about 7 or 8 and 9 or 10 at that time, an opportunity for them to experience a new country, live somewhere else. I'd also got pretty fed up with commuting, to be honest. I'd done a lot of extreme commuting at that point in my career to jobs, as well as working a day a week in a local practice. I think I was quite keen to change that and actually live somewhere like Dunedin, where I could easily live and work in the same place. But actually, it was primed because in terms of the trigger for actually moving to New Zealand, I'd spent a bit of time there in 2005 at the University of Otago in the Department of General Practice. And that was actually triggered for my PhD research. I'd done this PhD at University of Leicester in the late 90s, early noughties on ending the doctor-patient relationship. And that was the time when there was a qualitative research renaissance. Maybe renaissance isn't the right word. There was a qualitative research development of quantitative research and its use within health services research, particularly GP research. And one of my good colleagues, Chris Jay, at that point was the PhARMAC lecturer, senior lecturer in medical anthropology in my department, wrote a very nice paper in Family Practice, exploring the value of quantitative research for GP researchers. And through corresponding with her, I got to know a GP called Hamish Wilson in Dunedin, who was very interested in the work we've been doing. He'd done something similar in New Zealand, and I actually used the guidance because I developed some guidance for dealing with difficult patients from a thesis work, and I'd actually used that work with the New Zealand Medical Council. Actually works. So that's a sort of context. So it was serendipity, but it was. I do not think I'd have moved that if I'd not already had an existing relationship and had known people through my contacts. So I hope that answers that question.
Yeah,
So that's how I ended up. So I moved there in July. I took up the role I have now on the 1st of July 2014. So that's nearly 12. That's nearly 12 years.
Okay. And are there any kind of stark differences that you think are important to highlight between the UK and the New Zealand healthcare services and system as such?
Sure. Let me just start by emphasising the similarities. I think that's important. Yes. I think, first of all, universal access to healthcare, both in primary care and secondary care. There's a strong primary care GP gatekeeper role, and there is good use of team working within general practice and across the sector. And I would actually say that certainly in terms of consulting with PACIA, that is New Zealand European patients, the consultation form I found very straightforward. I didn't have any particular problems culturally working with PACIA patients coming to New Zealand. The purpose of this conversation is not around New Zealand's bicultural nature, but it's important to emphasise that. Mm-hmm. And of course, it's very important to learn ways of working with and being culturally safe with people from Maori and Pacific, who are Maori and Pacific. But that's the similarities. In terms of differences, there is a difference in primary health care. The public health system at secondary care level is very like the NHS. It is free at the point of use. It is free at the point of use. Public sector referrals point of use, but you have to pay to see a GP, except in very exceptional circumstances, usually charitable organisations. So there's a fee, and that goes back to the fact that New Zealand actually developed a socialised health system 10 years before the UK in the late 1930s. At that point, the doctors would have nothing to do with socialised healthcare. There seems to be, certainly in those days, probably, and maybe perhaps even now in certain areas, a view that people won't value anything unless you pay for it. So, GPs are private providers. And I always like to think of New Zealand general practice being a bit like the cat that sort of sits looking to go out or in, because it's a 50-50 system. It's got 50% capitation payment. I mean, that came in about over 20 years ago. So there is capitation payment and all the responsibilities for providing population level care through that. But 50% of your income comes from fee for service. So you can see, you could conceptualize yourself, as I might conceptualize what I do, as someone who is actually working in the public sector and providing public service, but receives a private copay. Or I might conceptualize my work as being essentially a private businessman or private practitioner, but drawing in some public work funding with a need to provide services. So I think that's the issue. And, so it does mean that financial issues are a barrier to access people. They can be mitigated. There is very low cost access clinics available, but it's usual to pay at least something towards what you see for your GP. I think there are advantages though. I think for primary healthcare in New Zealand using a private model. I think that's our entrepreneurism. The system has been very innovative over the years and has been able, I think, to develop innovative ways of using technology, for example, almost bottom-up approaches. So very early computerization of practice systems, very early use of patient portals, really good secondary primary care integration of referrals and also notes transfer. So, and actually much further ahead than secondary care in New Zealand. So actually there have been strengths, but that's different. Early adopter of technology, really. I suppose the other issue that's different, and I think probably goes beyond the health system, is remembering it's a small connected country with 2 degrees of separation. So relationships are really, really important. And it does mean that even when the system's under strain, our public health system is under great strain like the UK, the very similar pressures. We have a government that I would argue is destabilizing the public health system in this country at the moment and is favouring more private provision. Because it's small, the system is porous.
Yeah.
So if you ring up, someone will try to help and someone will get you through to the right person. And without going into medical details, as a recent patient, I have been hugely impressed with the intrinsic motivation, in this case of radiology staff, who were quite prepared to see that I'd only attended for one scan. I had another scan that was due in a different area. And well, I might as well do them together. It's much more efficient. We've got the capacity.
Wow.
And, I'm thinking about the NHS and I just can't see the NHS responding in that way. And the other thing I would say as well is that because the system is not fully public and it's not a monolithic public system in the NHS is, there's a lot of good use of third sector, not-for-profit organisations to provide care as well.
Okay.
So the cochlear implant that I will get is actually going to be provided by a charity that actually partners with the private hospital provider to deliver the services, but with public funding. But it's not a private. It is a charitable organisation that will support that. So I think it's just emphasising perhaps some of the need for some flexibility in the system. And I guess that brings me on to the last thing about New Zealand. I've pushed it about too much. The other thing is remembering that New Zealand has a NHS type secondary care, private primary care, and also has a social insurance model for accidents. So we actually have something called accident compensation corporation, whereby if you injure yourself, you get a subsidy for care. Anyway, there we are. I hope that's given
Really
you some ideas.
Yeah, really interesting. And yeah, there's definitely no one size fits all anywhere, is there? But I guess expanding on that a little bit with thinking about that interface across so primary and secondary care or secondary tertiary or whatever. Because things are, as you mentioned at the beginning, that primary care in New Zealand and in the UK, they're very multidisciplinary, team working situations. So, do you think that as we become increasingly more multidisciplinary, continuity, coordination, navigation of the system is becoming really, really difficult, or is that not something that's are the positives outweighing the negatives in a way, if that
Well, I
makes
think it is. Yeah, no, it does make sense. And look, I think it is becoming more complicated. It has to be. I mean, much easier when one person or two people held the ring on something, and there's many people involved. But I guess that we do have to recognise the strengths of primary healthcare as opposed to being a GP, the strengths of basically using different people with different skills in the team, and that is and through that you can provide more than one person or one discipline can provide, which is really important. And I guess I'm just thinking about, in relation to answering that, just thinking about the work of Jeannie Haggerty's work on defining continuity of care back in I think it was the early noughts in the BMJ, this idea of having three the redefinitions of informational continuity, management continuity, and relational continuity. I know we talk quite a lot about relational continuity because that's something I certainly really value, but informational continuity is critical. And I think, as I mentioned, having a shared record system, transfer of notes from preventative care will help inform that, and also management continuity as well. So I think that we need to work hard to fix that. I think from a New Zealand perspective, again, we can draw on the small connectedness of the country to say that we would bring people in from secondary care, if that's our provider, to talk to us, to get the relationship, to build a relationship, a working relationship with those people. And I think we would try and work as best we can with those people in those roles. I know that can be difficult. I know to system under stress, you can have a high turnover of staff, and that makes things difficult. But I do think, and in a New Zealand context, because New Zealand is a small connected country, that is different than the way the UK works. The UK is large, it's just big.
Yeah.
And I think you've got particular problems through that in terms of how, picking a city environment, it might be easier getting in the rural area if you know who the people are, because somehow or other you've got to get the people involved. It can't just be around using information and management continuity. You do have to somehow, I think, get the people involved with the care to meet, so you can sort of build a working relationship. And the argument, of course, behind that as well is also to try and, protect and grow intrinsic motivation of staff. I think that's critical. That people working in the health system do have high levels of intrinsic motivation, which basically means feel empowered to do the best thing they can for the patient, really. Which is what I was alluding to with the scan scenario earlier.
Yeah, the culture has to be in line with the values of continuity and things like that. I completely agree. And so you are, of course, a health services researcher and a GP. And is there ever any tension across those two roles, or do you find it very straightforward to balance them? And I'm sure you've had a lot of experience in doing so. So any tips you provide?
Well, I mean, I have to say that yes, we look after individuals and that we have to respond and discuss that care. But I do believe we're there to serve a defined population of people in the practice. And that's often usually geographically defined, or should be geographically defined if possible. And through that, we are there to focus on prevention, early intervention and community-based care to improve population health. So for me, I don't see that as a tension.
Okay.
Because that's how I would define my role as a GP. But given that definition, it's unlikely that I would want to work, for example, as an independent GP, perhaps providing services to a particular disease group, for example, that's now within primary care remit. That wouldn't be of interest for me. Yes. My passion would be delivery of essentially, primary care-based preventive health, really, as well as the issues I've said about providing relationally based generalist care.
Yeah, that's a really fresh and interesting perspective for me. Clearly I phrased the question in a fairly negative way, and then you flipped it on its head, which is great. But yes, I mean that's brings me to my last question of it sounds like the answer is a resounding yes. Do you feel able to be the type of GP that you want to be in the context within which you work? And again, I think you've already answered that with your explanation of that closing the loop and the fact that you are.
It has really, and I honestly think over my career, moving from being, as all academic GPs would usually do, where they would start off by doing the majority of their time working in a practice, sometimes as a partner, sometimes a salaried GP, due to a position now where I do a much more limited amount of clinical work due to other activities. I do feel I'd like to acknowledge all the practices I've worked in. The pleasure that almost, I mean, obviously in your career, I don't want to talk on negatives. I mean, I've had a partnership split early on in my career, but don't need to talk about that today. That's negative. I think the main thing is around the positives, around really at each point, both working in the UK and in New Zealand, I've been able to find the practice to work in with fantastic colleagues and to work in great functional small teams, which a good general practice does.
Yeah.
And in New Zealand as well, I think I've also had the opportunity. You could say it's a negative, and it is a negative that the charitable third sector has to provide care for the most vulnerable in society in New Zealand, for example, homeless people. But the positive is it allows me to work in a charitable third sector clinic to provide pro bono care to homeless people and also people with very high levels of physical and psychological comorbidity.
Yeah.
And, that is a real pleasure in a very small practice,
Mm.
with all the advantages of really having a small list, the ability to put people in depth, the ability to work relationally well with the team, particularly the nurses and other members of the primary healthcare team, and indeed with the relevant referral agencies. So, and I feel that I've been able to dovetail that with my academic work well in terms of being able to do both. So I have no regrets. I think it's been it's over 40 years now since I got my first degree in 1985. I think I've had a really good innings, to be honest.
Yeah. Great. Well, Tim, thank you so much for your time today and for sharing your experiences. Ngā mihi, and I wish you all the best.
Thank you. Thank you. Thank you, Emily.